Dr. Jim Hoyer. Jim is Professor of Laboratory Medicine and Pathology in our department. He's been a longtime member of our hematopathology group. He also directs what we call our metabolic hematology laboratory, and he's an internationally recognized expert in the evaluation of hemoglobins and other red cell abnormalities. Jim?
So that's forward, and the laser is there, and that's back.
Where do you point it? Just at the screen or anything? Well, good morning, everybody, and thank you, Kurt. My job is to talk to you about erythrocytosis in the 20 minutes that's been given to me. There we go. Here's my disclosure slide. So the objectives I have for this morning is to discuss the causes of hereditary erythrocytosis. I as well will show an algorithmic approach in the evaluation of these patients, and then I will apply the algorithm to two illustrative cases. Now, the definition of what constitutes erythrocytosis is somewhat variable in the literature, but these numbers I've listed here are often seen, and these come from the World Health Organization. If you have a hemoglobin of greater than 18.5 for men and 16.5 for women, or a hematocrit of 52% and 48% respectively, that's a pretty good definition. And these are greater than 3 standard deviations for most means. There's different ways that you can classify erythrocytosis, for example, primary versus secondary. Another way to do it is to ask the question, how long has the erythrocytosis been present? That's often the way you would approach this clinically. If it can be determined the patient had normal counts earlier and now has later developed an erythrocytosis, this would suggest an acquired cause. Conversely, if it can be determined that the erythrocytosis has been present the patient's entire life, this would strongly suggest a hereditary cause. Just briefly, these as a table listing some of the major causes of an acquired erythrocytosis. I don't need to go through polycythemia vera because Dr. He has already covered that. And I really don't want to spend too much time on this slide because this is not the focus of my talk, but just to point out many of the entities, particularly the cardiopulmonary and renal diseases, it should be evident from the patient's clinical history, perhaps physical findings or laboratory data, that this is a secondary phenomenon. And it gets back to Dr. Hansen's point earlier, how important it is to correlate testing with the clinical situation. Similarly, tumor-associated erythrocytosis, it's usually evident that there's an underlying malignancy, but every once in a while we see that the erythrocytosis is the first manifestation of an underlying malignancy. We all know about doping in athletes. And finally, patients that live at high altitude have different reference ranges from those that live at sea level. Here's the mutations, the hereditary mutations that cause erythrocytosis as we know them today. And I will be going through each one of these categories briefly. I'll start with high oxygen affinity hemoglobin variants. This is probably the first one that was known to cause hereditary erythrocytosis, and it's one that my laboratory has a lot of experience with. We can get mutations in either the alpha or beta globin chains, but it's typically the beta globin chain variants that cause the clinical symptoms, i.e. erythrocytosis, because the abnormal chains account for about 50% of the total beta chains. A lot of these high oxygen affinity variants can be picked up on routine methods performed by laboratories such as, say, alkaline electrophoresis or high-performance liquid chromatography, but it's important to note that some of these are electrophoretically silent, and this is due to what's called a neutral charge substitution. Almost all of the common methods used by laboratories utilize the principle that the way they separate out abnormal variants from normal is we get a charge substitution. So, for example, in the DNA, we get a nucleotide substitution that now codes for a different amino acid. What we're hoping to see is that the new amino acid side chain has a different charge from the one it's replacing. This then alters the overall charge of the hemoglobin molecule, and so it will separate on these methods, and we will see it as an extra band or peak. Now, if the new amino acid has the same side chain charge as the one it's replacing, that's the neutral charge substitution, and we simply won't see that it's present. So it goes without saying that you have to have a high index of suspicion in these cases of erythrocytosis, and a negative hemoglobin evaluation, depending on the laboratory that you send it to, may not be sufficient. In this regard, the oxygen dissociation curve is very valuable because in these cases of high oxygen affinity hemoglobin variants, the oxygen dissociation curve is almost always left shifted with a P50 down in the teens. Just showing an example of one of these, one that we've seen several times, hemoglobin San Diego. And you'll have to take my word for it that even though it's here, even though it doesn't look like it, we have an A peak, A2 on both of these methods here. So the San Diego is actually in here. It does not separate out on these methods. Turning to the next entity, the methemoglobin disorders, I'm only going to touch on this briefly because in these, the clinical picture is dominated by the cyanosis that's present. The erythrocytosis is a secondary phenomenon. These are usually quite evident what's going on, or at least they are usually suspected. The methemoglobin reductase deficiency, cytochrome B5 reductase, we usually can confirm this diagnosis by enzymatic methods. And the M hemoglobins are usually not too hard to identify on routine methods because they have these unique patterns on HPLC. For example, here's hemoglobin M Saskatoon, giving this very abnormal HPLC with a very high A2 and this other peak here. Every example of hemoglobin M Saskatoon looks very much like this. The next entity on the list is bisphosphoglycerate mutase deficiency. I've listed here the glycolytic pathway that red cells use for their energy production. This is a pathway that we all learned in medical school and then promptly forgot. But you can see, oops, that's not, sorry. We get glucose going down here to lactate and generating 2 molecules of ATP. Down here in about the middle, we have this shunt here where 1,3-BPG is formed into 2,3-BPG by the enzyme 2,3-DPG mutase. As you may remember, 2,3-BPG is very important. It actually binds to the hemoglobin molecule, and in short, when it binds, it facilitates oxygen unloading where it's needed out in peripheral tissues in situations of, say, hypoxia or acidosis. So if we can't make 2,3-BPG because we don't have any mutase enzyme, the oxygen dissociation curve becomes left shifted, and the patients get erythrocytosis. These are inherited in an autosomal recessive fashion, and they are extremely rare, fortunately. We have seen one case of this in my years at Mayo, a case, and we worked with Dr. Beutler. He did the sequencing for us. And when we look at the EPO receptor mutations, it's helpful to look at the physiology of the erythropoietin receptor. So over here on the left, here is EPO binding to its receptor. When it does, it forms a dimer. This causes JAK2, which is associated with the EPO receptor, to autophosphorylate. And when this happens, it then phosphorylates a whole bunch of tyrosine residues on the intracellular portion of the receptor, which serves to activate a whole host of signaling cascades, some positive, some negative. You can see here involved here STAT5. This is a positive regulator that increases gene transcription for genes involving cellular proliferation or anti-apoptosis. But there are also negative regulatories that come into play later, such as SHIP1 here, that are going to act to basically attenuate the response at a later point. The mutations in the erythropoietin receptor mutation that have been described are all truncation mutations where we lose this portion, which involves the negative regulatory elements of the receptor. STAT5 remains, and so now what we get is really unopposed upregulation of these genes. In fact, the erythropoietin receptor becomes exquisitely sensitive to even the smallest amounts of erythropoietin. So these truncation mutations all occur in exon 8. We lose that cytoplasmic intracellular domain, so we lose the negative regulatory region. I don't have it on this slide, but these are inherited in an autosomal dominant fashion. Erythropoietin levels are characteristically low. This is the only known cause of a primary congenital erythrocytosis. whereas P. vera is the only known cause of a primary acquired erythrocytosis, both involving, in essence, the same pathway. And the last entry, mutations in the oxygen sensing pathway. There's been an awful lot of work that's happened in, say, the last 10 or 15 years to unravel how this pathway works, and there are now mutations involved in all of these genes as I've listed here. And to understand the mutations that occur in the oxygen sensing pathway, it's very helpful to go through the normal physiology of this pathway. And I would say that this occurs in all cells, not just red cells. This oxygen sensing pathway is very important for all cells. There are three main players in this pathway, and they're listed here: hypoxia-inducible factor, or HIF, prolyl hydrogenase domain, or PhD, and von Hippel-Lindau, or VHL. There are three isoforms of the first two, HIF 1, 2, and 3, and PhD 1, 2, and 3. For the purposes of the red cell and erythrocytosis, the important ones are HIF 2 and PhD 2. So in the normal oxygen sensing pathway, what happens is when we've got abundant oxygen, the HIF alpha subunit is hydroxylated by PhD2 at these two very specific proline residues. When this happens, this serves as the recognition point for the VHL protein. This then binds to HIF alpha, and along with ubiquitin, we get degradation of this HIF alpha subunit. Now, in conditions of hypoxia, where there's not enough oxygen, this hydroxylation then can't occur because it needs oxygen. The HIF alpha subunit persists. It then binds to its stable subunit partner HIF beta. This complex then binds to a whole bunch of genes, over 100 of them at the area. You can see it's the hypoxia response element. This is typically promoter or enhancer areas to upregulate these genes involving erythropoiesis, angiogenesis, and glucose metabolism. For example, one very important one is actually the erythropoietin gene. So you can summarize mutations in the oxygen sensing pathway by saying mutations in any one of these three proteins or its genes, and then the proteins HIF, PhD2, and VHL will mimic a situation that is a hypoxic situation. In other words, persistence of the HIF alpha subunit binding and then upregulation. I just want to point out those two prolines are located at positions 405 and 531. So looking first at the HIF2 alpha mutations, these are inherited in an autosomal dominant pattern. Erythropoietin levels are normal or high. The vast majority of the original ones described were in exon 12. This is the exon in which proline 531 is located. And these all have a common theme in that the amino acid substitution interferes with PhD2 hydroxylation at that proline 531. More recently, now we've found mutations in exon 9, which is the location of the other proline 405, with a similar mechanism occurring. For the PhD2, also inherited in an autosomal dominant pattern, EPO levels are usually normal. There are several different types of mutations. I don't have time to specifically go into them, but we can summarize by saying the common theme is disruption of the PhD2 catalytic domain such that it cannot now enzymatically hydroxylate those residues on the HIF2 alpha. And then finally, the VHL mutations inherited in an autosomal recessive inheritance. This is the classic mutation here. This one is the Chuvash mutation found in the region in Russia, Chuvashia. It's been long known there's an area of patients that have families that have this high red cell counts, but there have now been other mutations discovered, and the Chuvash mutation has been discovered in other areas. There's an area in Italy and in Pakistan where it's located. So now we are also seeing compound heterozygotes. Typically, one is the Chuvash, and one is the some other mutation. These are very characteristic, and they have markedly elevated EPO levels. One more thing I was going to say. The mechanism for the VHL abnormalities is not really known, but it must be that the mutation in the VHL is affecting its ability to bind to the HIF alpha subunit. So because, at least in two of the genes, the mutations are centered in a specific exon, these disorders are very amenable to simple Sanger sequencing. So for the EPO, all we need to do is look at exon 8 for HIF2 alpha, exon 12, and now exon 9. And the other two genes are also easy because they're relatively small, so it's not a big deal to just sequence the whole gene. So these disorders lend themselves to an algorithmic approach, and I want to point out, you'll notice my algorithm isn't as busy as everybody else's algorithm, so, and it's prettier looking too, I think. So the entry point into the algorithm is a JAK2 V617F and serum EPO. And the reason for this is even though the history may suggest strongly that it's a congenital or cause, hereditary cause, our input is that virtually all clinicians still would like to rule out the possibility of P-Vera given its clinical implications. And also as well, by the time the testing gets to my laboratory, this has usually been done. If we do the JAK2 V617F and it's positive, basically it's P-Vera. There's no need to do any of this other testing. If it is negative and the EPO, we look at the EPO next. If it is low, we would do, perhaps if the history is still ambiguous, do exon 12. If it looks to be hereditary, we would then go to the erythropoietin receptor. Now, if the EPO is normal or high, and we can establish that there appears to be a lifelong erythrocytosis, the next step is to do the P50. If low, all the entities that I've described here, and if it's normal, then we look at the oxygen sensing pathway. So let's apply this to these two cases. The first is a 19-year-old a male of African heritage. He has erythrocytosis. He's had headaches and chest pain all of his life. He smokes 3 cigarettes per day. His physical exam is unremarkable, meaning he has no organomegaly. Interestingly, his father and other family members also have headaches. They have ruddy faces. His cardiac history is only significant for a right bundle branch block. Here is his CBC. You can see the markedly elevated hemoglobin, hematocrit, and red blood count. Interestingly, though, he also has a microcytosis. White cells and platelets are normal. Here's the initial testing, negative or normal for both. So we are going down this part of the algorithm. We are down here, and we have a history that suggests a lifetime erythrocytosis. So the next step is to do the oxygen dissociation curve, and you can see it is markedly left shifted. Normal value for P50 in our lab is 24 to 30 micromillimeters of mercury. So here is his hemoglobin electrophoresis. There is a variant present here, and here it is on HPLC. Those of you who may have patients with hemoglobins might know that this is consistent with hemoglobin Lepore, very characteristic, which actually creates a problem because the Lepore will explain this here, but the Lepore does not explain this and the high red count. As well, it does not explain the abnormal P50, so we need to work this up further because there's still a possibility there's a high oxygen affinity variant there, a silent one. And in fact, DNA sequencing and mass spec show that there's a variant that's been called hemoglobin Johnstown present. So that peak there that looked to be A on our methods was actually not hemoglobin A, that's all hemoglobin Johnstown. Next case, a 12-year-old American girl of Spanish heritage. She's been noted as far back as her 10-month well baby exam to have high hemoglobins. You can see the range here. Normal for her age is right here. Otherwise, she feels great. No family history, no cardiac or pulmonary disorders. Here we go. Here's her CBC values. Apart from the high red counts, the other values are normal. And here is her initial testing. Once again, normal. So we are here as well, coming down this part. It looks to be lifelong erythrocytosis. Once again, next step, P50. And here, this one is normal. Now, hemoglobin studies did not to be done. They were actually done in parallel, and you can see here that it looks normal, and you know there's no high oxygen affinity variant because the P50 was normal. This puts us then down going into the oxygen sensing pathway. The PhD2 testing was normal, VHL was normal, but lo and behold, there was an abnormality in the HIF2 alpha at position 534. How am I doing, Kurt, time-wise? Couple minutes, okay. I will just say these patients are out there. As we've been doing this testing, there's a list of patients that we presented at the ISLH meeting last May. And you can see this patient here. Where is she? The little girl is right here that I just presented as part of this list. And given time constraints, I won't go through these individually, but they are in your handout, part of the slides. But just to say, you can see we saw 2 erythropoietin receptor mutations. We've seen 5 PHD2s, 2 HIF2 alphas. And the mechanism for all these in fact, are all previously unreported mutations. The mechanisms are all virtually the same as what I've already talked about. So I will skip ahead here. And summarize and say many of the causes of erythrocytosis we now know. We're much further along now than we were, say, 20 years ago. I hope I'd shown that these cases of secondary erythrocytosis lend themselves to an algorithmic approach to direct appropriate testing and hopefully allow effective utilization of the testing and reduce unnecessary costs. But there's still a long way to go. This is a paper that came out last year. This is a primarily Portuguese group. They had a series of 70 patients who had erythrocytosis, but they found the cause in really not even half. It was less than half of cases. So there's still things out there that we don't know about yet that are yet to be discovered. Thank you. Hold a minute.